Thank you all. All right. Thank you all for joining. I'm really excited about talking to you about this topic. It's something that's a passion of mine. So I'm going to stop my video just to make sure I don't get um, caught off guard here. All right. So today I'm going to talk about chronic wounds, and many understand it is kind of what we call the silent epidemic. I'm excited to kick off this exciting journey into the wound care. My aim is to dive into what really is biofilm, some of those methods and strategies to tackle that biofilm, some current perspectives on how we can systematically approach those wounds, and we can explore the challenges and opportunities that we face moving forward. My background in healthcare covers much ground from critical care, perioperative services to quality and case management. For the last 3 years, I've focused on wound care as a medical science liaison and a representative, introducing some innovative wound care products. I believe this experience has really given me a really deeper understanding and appreciation of the complexities in healthcare across the board, specifically related to wound care. So many have asked me why I moved into the medical device sector and into wounds specifically. It is an unconventional path many nurses choose to take, but I have really appreciated what I've gained from it. The decision to go into wound care was not really made lightly. It's a personal and strategic move. My mother passed away due to bilateral foot ulcers. She was diabetic. She probably was a little non-compliant, as we like to label people. But I am driven by the belief that possibly if there were some advancements in wound care, it could have improved her quality of life and possibly uh, extended her time with us. Today, we're going to dive into biofilm. We're going to look at some strategies to tackle it, though there are always challenges to that. I'll also touch on some wound balance, the different products and therapies we can use. Also, some infectious disease issues, and I'll point out some opportunities and challenges that we need to consider. I'll close with some innovative ideas that I reviewed from a recent consensus study that really caught my attention, especially since I've been in the medical device industry and I've seen the challenges patients face specifically with managing their wounds. So, as we all know, wounds have an impact on healthcare and communities globally. You might be familiar with some of these statistics that I'm sharing with you and the research that's out there, but there's something crucial I want to highlight. Despite all the advances in treatment and newer products, we still struggle with wound care. For example, you'll see here back in 2014, about 14% of Medicare beneficiaries in the U.S. had chronic wounds. Fast forward to 2019, that number jumped to 16.3%. You may think that's not a lot but when you're talking about millions of people, that is a significant portion of our population. Given that our population is aging, I wouldn't be surprised if that number has increased even more. This situation significantly affects diabetic patients, making it a silent epidemic worldwide. Hearing about other health crises like the flu and measles, I'm sure you guys are chasing that tail constantly, and I'm a huge flu vaccine supporter. When I worked at Norton, that was one of my initiatives I helped lead as far as improving that vaccination rate. Though these are serious, no doubt, we can't ignore the fact that wounds are getting worse, leading to unnecessary suffering and even death as well. We need to tackle this issue as a public health crisis and reevaluate our approach. This presentation will look into some of those fresh insights, and I want to kind of help people understand how we really need to better assess and treat these wounds, whether you're really in the acute or post-acute setting. This is a topic that I've really talked about in detail over the last 3 years, and something I've learned a whole lot about. Over the past 3 years, I've uncovered this fascinating yet formidable world and its pivotal role in wound healing. It's astonishing that many clinical nurses and healthcare providers are often in the dark about tackling this hidden menace effectively. Biofilm is no ordinary foe. Back in 1978, Costerton published his first article about biofilm and how it has only been in recent years, though, we've begun to really embrace the impact biofilm has had on all functions of life, including health, our dental health, and even the pipelines. Biofilm is found on your teeth. That's what is your plaque. And many people don't even realize that. And the only way you remove plaque is to scrape that off. Biofilm is a thriving community of pathogens encapsulating bacteria and fungi. It's in this intricate web we call the extracellular polymeric substance. It's this real sticky substance you see on the screen made up of polymers, proteins, polysaccharides, and they're held together by metal ions, which is key to breaking that biofilm apart. This clever structure enables that biofilm to flourish and fend off treatments with remarkable resilience. I didn't know if you all know that 80% of human infections are tied to biofilm. This battle-hardened formation showcases an astonishing 10,000 to 100,000 times more antibiotic resistance than free-floating or what we call planktonic bacteria. It's definitely a game changer, especially when our research reveals that a whopping 60% to 90% of chronic wounds harbor biofilm. This makes it a crucial challenge in the realm of wound care. Even more alarming, antimicrobial resistance claims about 10 million lives globally every year. Studies from the Mayo Clinic have shown that biofilm can often make its presence felt right from the first assessment of a wound, complicating that path to recovery. So we must act decisively. It's vital to reduce that bioburden, stave off that biofilm growth, breaking down the barriers this tenacious entity poses in wound management. The fight is on, and understanding biofilm will be key to this victorious healing, though it is complicated. Now that you know what biofilm is, how does it lead to chronic wounds and infections? Well, first, this illustration shows how bacteria form biofilms like little communities that stick to surfaces. At first, bacteria can easily attach themselves, and it's simple to remove them at this stage. But as they grow, they create this protective layer that helps them thrive and communicate with one another. And eventually, some bacteria may break away, as you see in the slide. They become planktonic, and they lead to new infections. These bacteria produce special substances such as the EPS, and they, again, act like that armor to keep themselves safe. It's amazing how the bacteria essentially create this little community, and they are able to start speaking to each other to support their community. Interestingly, about 90% of the bacteria live within this biofilm, making them tough to eliminate, while only 10% are free-floating. If we manage to destroy part of the biofilm, the remaining bacteria can quickly make a comeback. This is one reason why infections like UTIs, urinary tract infections, can return again and again. So understanding this helps us appreciate the challenges that we're dealing with such persistent infections. So biofilm formation can occur at an alarming speed, with established colonies developing as little as 2 hours. In the context of debridement or antimicrobial intervention, it's crucial to assess whether the selected approach can adequately penetrate and eliminate biofilm, particularly the subsurface layers that shield it. Moreover, the efficacy of any treatment strategy hinges on the ability of the host's innate immune response to counteract the virulent factors associated with biofilm, as this interplay is vital for therapeutic success. This figure I really like, is it really highlights those key phases in wound healing that I refer to as a sweet spot position between vigilance and intervention. So when you look at the bottom of the screen, you'll see that you'll have the vigilance is required. So you have the biofilm or the bacteria come in, they contaminate, and they colonize. But if you don't stop it and it starts reaching to that localized infection, then you're going to see that the biofilm and the bioburden gets to the point that the patient's own response is not, the host response is not able to overcome this attack. This is, so a colleague of mine and I and Dr. Rogolski put together an article related to biofilm and how it impacts older adults in acute care setting. And I love this picture because I think as nurses, my experience in all the areas that I've worked, we never really talked about this level of why we see infections. And I think it really is helpful to show this depiction as to The bacteria actually gets into that into the skin through just that catheter insertion alone. So many peers and colleagues recognize the challenge of central line urinary catheter infections, yet we often lack that training to understand the root cause. So forming biofilm during central line is critical, as planktonic bacteria, you'll see, can attach to that catheter tip or hub, ultimately entering the body. So preventing infection starts at the very beginning of procedures. While we have introduced specialized dressings and patches to mitigate these risks, we have to remember that bacteria are part of our body's environment, but how do we control that where it reaches the infection and where we cannot no longer overcome the bioburden that has been introduced? Now that we know what biofilm is, how quickly it can evade its target, and how easily it is introduced into a clean environment and become virulent, let's talk about some strategies proposed to target biofilm. Biofilm is highly virulent, and attempts to attack it can sometimes increase it. So if you try to remove the biofilm, I say the bacteria get very angry, and they want to build more and more communities. So it's kind of like when you watch these medieval times and these structures and the castles, and they get attacked, and boy, they get meaner, and they start attacking more, and then they build more resistance, and that's exactly what biofilm and the bacteria within it do. So practical strategies to combat biofilm must take several factors into account. When we look at antimicrobials, they often struggle to penetrate the EPS structure that makes up biofilm, and they may be non-selective or even cytotoxic. The EPS can also assume these agents before they reach the pathogens, and most antimicrobials are not designed to penetrate biofilms effectively. This raises concerns, as we all know, about antimicrobial resistance. Sharp debridement is a common intervention, and it can be a gold standard early on to attack the bioburden, but may only address the visible layers of biofilm, allowing underlying pathogens such as Pseudomonas to remain. Dispersing agents like surfactants can dissolve biofilms and promote microbial lysis. These agents are typically broad spectrum, compatible with host tissue, and they can help contain a barrier against biofilm formation. So considering these factors is crucial when developing strategies for biofilm management, when developing a biofilm management strategy. As I was preparing this presentation, I was digging deeper into some different theories and frameworks that different groups of providers and have put together. And one of the things I really liked was where Garten et al. Really highlighted the concept of what they call wound balance, not wound management, not wound care, but it's essential for effective wound healing. They say that wound care should be focused on clinical intention, not just management. Healing is a journey. It unites the patient, their healthcare provider, their family in a shared purpose. So some key concepts they pointed out is, first of all, you want to make your treatment decisions rooted in evidence. Base those practices on evidence, and you want to inspire confidence in the care. We have to prioritize the needs of the patient and their family, recognizing that they are vital, they play a vital role in the healing process. And we all are familiar with this, but in my experience out in the field, believe it or not, it's not always present. Oops, sorry. So, really looking at research, how do we diagnose to make sure we're treating appropriately? Are there some quality of life measurements we can use? And then also, how do we support the continuity of practice across the patient's journey and make sure that they're getting the right care? Successful wound healing is influenced by several factors. Obviously, a thorough assessment of the wound and the patient's overall health is essential. This really should happen every 7 days. I can say sometimes it doesn't. Some of that more related to the patient not coming to the wound care center or following up, but it should be focused on the individual needs and goals. We really need to stop talking about how we need to heal the wound. Sometimes it's palliative. So what is the goal for that patient? Infection control obviously is paramount, and I'll talk a little bit about that here in a minute. Um, Sorry, my screens just keep. Um, Nutrition, sometimes this is really overlooked when I've talked to some patients, really understanding what are their nutritional deficits. You got to have the adequate nutrients in order to repair that tissue. One thing that is also somewhat overlooked is pain management. If you have unmanaged pain, now a lot of patients actually have neuropathy and they don't feel the pain, but some patients do. And in my experience, observing patients and assessments, that sometimes is overlooked because there's an assumption that they have no pain or issues with that. I won't dig too deep into this, but I did want to point out I really like this time framework. It's a helpful approach to assess wounds, ensuring that we look at every vital part of the best healing result. So you want to make sure that you're looking at the tissue. You'd have to do a clear evaluation of what type of tissue there is, how much biofilm there may be. Slough is a sign of biofilm. Also, you want to consider what type of debridement methods you're going to use in order to ensure that you're not only debriding for the biofilm, but you're also making sure that you're avoiding causing any injury to the healthy tissue. The next thing is inflammation. When you're looking at inflammation, you have to look at, you might look at topical antimicrobials and systemic antibiotics, but you got to make sure that you are utilizing those at the right time. And again, we'll get to some diagnostics, but you don't want to just implement any topical antimicrobial or systemic antibiotic because, as I said, most of your bacteria that's within this infection is going to be encapsulated in the biofilm. And then other considerations is going to be looking at that epithelial edge advancement. Typically, you want to look at a wound that the rule of thumb is that you want at least a 50% reduction in wound edge and size within the 4 weeks. But typically, within the first couple of weeks, you're going to tell if that strategy that you've put in place is making any progress or not. Another important key factor I want to point out is the moisture imbalance. You've got to understand that the exudate status of the wound, you've got to remove that. If you have too much excess, exudate does aid in healing, but if you have excess levels, this will cause the maceration and biofilms, they love that. So definitely managing the exudate. So I really like this. I don't have time to really go into it in depth, but it's definitely a great framework to use when we're looking at wounds and how can we implement that even within the nursing setting. So when you're treating wounds, there is kind of a rule of thumb, and this is from Dr. Schultz et al. From 2017. Essentially, you want to make sure at every wound visit you're assessing, you have proper diagnoses. You want to debride aggressively early on, and then maybe do some maintenance debridement after. You do consider some empiric topical antiseptics and antibiotics, and then of course you need to manage what the host factors are, and then considering those advanced therapies when appropriate. So infectious disease considerations. This is really fun. So wounds are highly susceptible to contamination, making that accurate bacterial bioburden assessment essential. As I mentioned, planktonic bacteria float freely while biofilm bacteria adhere to the surfaces, and they often evade traditional detection methods. So for example, I said Pseudomonas can thrive deep in the tissue and it's very difficult to detect. The Erickson consensus study advocates for DNA identification techniques as standard deep tissue cultures recover only about 20% of bacteria. The complex structure of biofilms complicates detection further. PCR panels like the microgen test combined with next generation sequencing enhance identification capabilities from sterile sites or well collected specimens such as tissue samples and body fluids. There's also there's a product out there, it's called Moleculite, that some folks are using, a lot of your offices are using. It's kind of a wound management, multimodal visual, trying to detect biofilm and presence of infection. It's quite interesting. But, really my experience in the hospital has been, we do culture and sensitivity, but when you really look at what we're really able to capture, it may not be the most ideal when we're treating these wounds. So I can't get into a lot of detail. This could be a whole other presentation. But in the realm of wound care, there's certainly a wide variety of products that we can choose from. They're designed for specific needs. It's critical that we select that appropriate product at the right time and understand how to use it effectively. And I cannot emphasize how that's a missed, that is definitely an opportunity out there. So, for example, you shouldn't use a hydrogel dressing for a highly exudating wound. You definitely want to use something that's more super absorbent. So you've got to really consider the characteristics and stage of healing, as well as the care plan that's been developed with the patient. You've got to consider cost, accessibility. One of the things that I talked to a wound care center about is in the hospital, they may put on a wound vac. They send the patient home. The patient goes to a wound care center. That wound care center has to change that wound vac because now the wound vac that's on there is meant to be changed every 2 or 3 days, whereas this patient may only be seen once a week for certain specific reasons. So we really have to think about that. Again, this just kind of points out just the basics, and that, again, that can be a whole other conversation. Something I do want to point out about dressings that is really important, especially those who care for the patients at the bedside, to understand the reason. Keith et al. Highlight the necessity of eliminating the gap between the wound bed and the dressing to prevent delays in healing and reduce infection risk. Now, within the wound care realm, it's somewhat known that this is important, but also when I've spoken with people across the region of the United States, that seems to it seems to kind of go by the wayside. Proper dressing selection is vital for moisture control, minimizing those gaps so that we can foster better wound healing or maintenance. So, for example, in my experience, I've seen compression dressings that are placed. Well, the whole point of that is to compress the wound to help with that healing and process. But I've noticed that they become loose. So when those dressings become loose, like you put an ACE wrap or something on there, is it really providing the compression that it's meant to be? And there are compression devices out there that can maintain that pressure. But, many times you'll see somebody with a compression dressing on and it's falling down their leg. Obviously, some providers I've seen and wound care clinics and even nurse practitioners, they'll sometimes turn patients away because of the offloading. So the patient will refuse to offload. They'll continue to do what they want. And if you don't offload, it only takes a few steps for you to take yourself back about 7 days in wound healing. So there are some real critical things that we need to consider when we're looking at products to help offload, et cetera. What are some of the challenges? There's a lot out there. We have to have a comprehensive approach that centers on the patient and their family. Garden et al. Highlights that tagging patients as non-compliant is unproductive. We've got to create obstacles. He suggests that we have healthcare teams cultivate a therapeutic and communicative relationship. One of the things that I have learned across the board, there's a lack of education and training required. I mean, this is a silent epidemic, and there is no special training for providers. I know there's a lot of nurse practitioners out there that maybe new nurses that become wound care nurses, and they've done phenomenal work. They all have, but there really is no specialized training to become a wound care provider, or we even see it at the bedside. We have very minimal knowledge. Again, there are definite gaps in continuity of care. I mentioned the one about the wound vac. Sometimes, even with products, a patient's admitted to acute care or discharged, and the patient may or may not have access to be able to get those products. So there's a lot of things we got to consider when we're looking at wound care across the care continuum. Um, a big issue that we have across the board, and anyone in wound care will talk to you about this, is the standardization of care. There really is no standardization, despite there's consensus studies out there that talk about key therapeutic approaches. The optimal intervention methods and timing still remain unclear. There's a lot of opportunities, and all of us need to look at how we can move toward that. So a couple of things before I close up. I saw an article that was very interesting. It's Erickson's consensus. They mentioned a smart dressing versus an imitation dressing. So essentially, have a dressing that can basically diagnose the wound, which is interesting, and diagnose that bile burden. Look at some more antimicrobial antibiotic options that help preserve the wound cells versus possibly being cytotoxic. And then finally, how do we, for the sake of the patients, how do we integrate topical pain treatment into already utilized products? So in conclusion, the key takeaways I want from this presentation, hopefully, is basically addressing the biofilm. A thorough assessment, a targeted plan are vital for success. Appropriate diagnostic testing will empower us to ensure that any topical antimicrobial or antibiotic we use directly and effectively targets that bacteria and biofilm. Understanding the right dressings for wounds is crucial. Our choices can either propel the healing journey forward or impede it. So let's commit to making informed decisions that foster healing and restoration. Remember, every wound tells a story, and every patient deserves our best care. Let's continue to innovate, collaborate, strive for excellence in wound management, and together we can make a significant difference in the lives of our patients. And that is it.
Anyone have any questions for Dr. Marguet? I will say I think it's, fascinating, the idea, if you will, of biofilms. And I do think that, we underestimate the impact that has on causing of hospital-acquired infections or infections in general, and the difficulty that it is to treat those infections once they're there. All right. Well, if no one has any questions, thank you all very much. We'll see you at the next infectious disease grand rounds, and we will have this posted onto our YouTube channel for future viewing. So if anyone wants to reference someone back, please feel free. Thank you all and have a lovely day.
Thank you.